This is Dr. Singh. Guys, I'm back. Let's talk about tachyarrhythmias. And in section, we are covering atrial fibrillation / flutter. I think it's a big topic, and I'll try to cover in 15 minutes if possible. Atrial fibrillation, that's your heart. SA node, AV node, his bundle, left bundle, right bundle. In some people, you have a lot of re-entry circuits around the pulmonary veins in the left atrium. You have 4 pulmonary veins emptying the blood into left atrium, and for some reason, and I'll talk about etiology, they have a lot of re-entry circuits, and it beats at 400 to 600 beats per minute. The rule in cardiology is whosoever beats faster going to be the boss. Sinus node beats 60 or above, so sinus node is the boss for your entire life probably, until you go into something like atrial fibrillation, when you have something beating at 400 beats per minute. So sinus node is going to go to sleep now. So you have AV node saving us. You do not have 400 beats going downstairs in the ventricle, people would be dead. So who is saving us? AV node. The decremental property of AV node is saving us. So out of these 400 beats, 150 to 180, or depending upon, they go downstairs, and people come to the ER and you get a call, hey, I have somebody with Afib with RVR, come admit the patient, right? So they are alive, they are beating at 150, 160, 180, but they're alive, they're not dead. Etiology wise, you have a hypertension, you have ischemic heart disease, lot of drinking, hyperthyroidism. And a lot of underlying etiology which is situational, like somebody coming in with a respiratory failure, somebody coming in with a GI bleed, somebody coming in with a septic shock or sepsis. They all can go into atrial fibrillation for a brief period of time. That could be hours, could be day, or less than that. So what you guys need to know, these two are the big players in etiology. This is the most common arrhythmia you guys are going to see, especially in people more than 60 years old. I can promise you that this is the most common arrhythmia you will see in your life. There is something called post-op Afib, and this is very different from what we have talked about so far. Post-op is patient had a surgical procedure including CABG, valve replacement, or any other hip replacement. After that, they go into atrial fibrillation. We call it post-op Afib, and that is totally different categorization for the atrial fibrillation. Technically speaking, when they explain, they want you guys, and I don't understand why they want to differentiate this. They want to call it as paroxysmal Afib if this is less than 7 days duration. And you go back to sinus by yourself or some kind of chemical modality. Paroxysmal Afib. There is something called persistent. Persistent means lasting more than 7 days. Third category is long-standing. Long-standing. Long-standing is more than 12 months. And there is something called permanent Afib. Permanent Afib. When you know that person is in Afib, person has failed all the cardioversions possible, and there is a mutual acceptance between the cardiologist and the patient, thinking this is something they have to live with. We call it permanent Afib. Long-standing is 12 months, persistent is 7 days, paroxysmal Afib is that goes back to sinus within 7 days, right? That's how you classify it. How do you want to treat these people? To keep things simple, there are 5 ways you can treat. Treatment itself and anticoagulation. There are 2 arms of the treatment. AC means anticoagulation, and I'll talk about that in a second. Treatment per se is there are 5 modalities you should know, 5 ways you can treat atrial fibrillation, and that is rate control, rhythm control, cardioversion. DCCV means cardioversion. 4th modality is atrial fibrillation ablation. Another modality is AV node ablation. AV node ablation. I'll tell you what exactly you need to know about atrial fibrillation. 5 modalities you want to treat these people with. Rate control simply means give them calcium channel blockers or beta blockers, provided their ejection fraction is not bad and provided their blood pressure can tolerate this and they do not have a lot of symptoms. You do what? Rate control. Rhythm control simply means they have a lot of symptoms. They have a lot of symptoms. Why? Because around 20 to 30% of your ejection fraction, the contribution comes from atrial kick. Your atria contracts completely, adding to ejection fraction. If a young person, you're 40 years old, you may not feel it. But if you're 70 years old, your EF is low, you're going to feel the loss of that atrial kick. So people would go with rhythm control simply means you give them antiarrhythmic therapy that includes class 1 or class 3 antiarrhythmics, and that will be a separate lecture. 3rd modality is cardioversion. Simply means this could be 2 ways. This could be for stable people and this could be for unstable people. Unstable means somebody coming to the ER with a chest pain, short of breath, they have RVR with a rate of 180 beats per minute, their blood pressure less than 80. In emergency, you cardiovert these people. This is emergency procedure, right? Stable people means people who want to be converted back to sinus, and you can combine these 2 together. Many times we shock them and we try calcium channel blockers and beta blockers to see if they stay in their normal rhythm. And if they don't, many times we combine calcium channel blocker, beta blockers and antiarrhythmics together, but antiarrhythmics by themselves, they do not do cardioversion. Sometimes they do, but you do cardioversion and let the medications take over. So you can combine these 2 modalities for rhythm control. Again, why do you want to go to rhythm control? People with lot of symptoms. Atrial fibrillation ablation is your next step, and again there are a lot of complications for Afib as well, and a failure rate for ablation is pretty high. So you want to try everything possible before you go for Afib ablation. That's your next step. Perfect patient is going to be somebody who has tried antiarrhythmics therapy before, who has tried cardioversions before, who is already on calcium channel blockers, already on beta blockers. They are still symptomatic and going back into Afib, you do not have any choice but to ablate it. AV node ablation is a board question for internal medicine nowadays, cardiology of course. These are the people who already have a device like BiV. BiV means you have a lead in the right ventricle and you have a lead outside the left ventricle to synchronize left ventricle. They're already pacing 99% of the time they are pacing. So if your device is pacing for you 99% of the time, why do we need AV node? So these are the people who are very difficult to control with BiV. Their pacing is never 99%. Why? Because they're in atrial fibrillation all the time. So what you can do is, in these people, you can do AV node ablation and let the BiV take over doing 100% pacing for them. Again, when you have tried everything and patient is still symptomatic, BiV is not working because of an atrial fibrillation, and they already have the device in there, you can do AV node ablation. You do not do AV node ablation and then put the device. Okay, understand that. They already have a device. All you want to do is cut the connection between the atria and the ventricle. All right, guys. Again, 5 modalities you treat the atrial fibrillation is what? Rate control, rhythm control, cardioversion, Afib ablation, AV node ablation. Next arm of the treatment is anticoagulation. Anticoagulation. Anticoagulation means these people, they are at risk to get stroke. That means what? Because your atria and small appendage on the side, they are not beating well. They are just quivering. They're not beating well. So blood is going to stay here and make a clot. This clot stays here and it can travel to left ventricle. And you all know if it goes to left ventricle, it's going to go to the brain eventually. These people come in with stroke. How do you want to prevent these people from stroke? By giving them Coumadin or newer therapies like dabigatran, rivaroxaban, apixaban. All right, guys, you can go with Coumadin versus these newer agents. And the most important differentiation between these two is you should know what is valvular Afib and what is non-valvular Afib. It's a very important question for you guys. Is it valvular or is non-valvular? And you are going to hear this a lot. Valvular Afib is mitral stenosis, mitral repair, or anybody with artificial valve, whether it's metallic or it's bioprosthetic. These are the 3 things under valvular Afib. Everything else is non-valvular Afib. These 3 medications, there is a good side and the bad side. Good side is you don't need to check INR. Bad side is there is no reversal agent except this one. Recently they came with. Bad side is no reversal agent. It may not be true in next few months or few years, but you don't need to check INR. You swallow the pill once or twice a day. That's a good side about these medications. Can we use this medication in valvular Afib? At this point, no. The answer is no. If you have one of these conditions, which is valvular Afib, you have to go to Coumadin. You have to go to Coumadin. Who else needs Coumadin? If this is valvular, of course, and if this patient is on hemodialysis. For the time being, Coumadin is your only way to go. Who needs Coumadin or one of these agents? There is a score called CHAD-VASc. It used to be CHAD's score in the past, CHAD's 2 score in the past. Lately, we call it CHAD-VASc, CHA2DS2VASc together. So that's the score. Why are we trying to shift from CHADs to CHAD-VASc? They want us to anticoagulate more people, and have a lower threshold who needs anticoagulation, who does not. C means congestive heart failure. You have a score of 1. H is hypertension. You have another score of 1. A is age more than 75. You have a score of 2. D is diabetes, score of 1. S is stroke or TIA, score of 2. V is vascular disease, score of 1. A is age 65 to 74, score of 1. SC is sex category. If this is a female, you have to add another score of 1. Anytime the collective score is 2 or above, again, magic number is what? Score of 2 or above. You want this person to be on either Coumadin or one of these agents. And there are some exceptions. Again, there are 2 arms of treatment to treat atrial fibrillation, 5 modalities: rate control, rhythm control, cardioversion, Afib ablation, AV node ablation. Another arm to the treatment is anticoagulation. AC is anticoagulation, which you can do with warfarin or Coumadin or one of these newer agents. You don't need to check INR in these cases, but make sure you understand what is valvular, what is non-valvular. Valvular is either MS mitral repair, or artificial valve, either metallic or bioprosthetic. Who needs anticoagulation? If their CHAD-VASc score is 2 or above. Let me give you some examples now. Mr. Smith comes to the ER with Afib with RVR. His heart rate is 170 beats per minute. His blood pressure is 150 over 90. There is no medical history at all, other than the fact that he drinks 1 liter of vodka every day. His blood alcohol level is 400. How do you want to treat it? The best answer in this case is go with cardism drip. Why? Because you need to control the heart rate, and the blood pressure is good enough to tolerate cardism drip. If this person has a history of, say, example, this person has a history of hypertension and diabetes. So technically, and I can tell you this guy is 49 years old. So his CHAD-VASc score is at least 2, right? Technically, he needs anticoagulation, but again, if he drinks 1 liter vodka, do not anticoagulate and waste your time and money on this guy anticoagulating and trying to prevent a stroke. Why? It's a risky thing. Most of these people, they come to the ER, they are in sinus rhythm next day morning, and they sign themselves out. Why? Because they want to go home and drink again. Again, if they're drinking so much, no anticoagulation, cardism is good for them. Scenario number 2, Mr. Smith Are we good on the time, John?
Yes.
Mr. Smith comes to the ER, and this time Mr. Smith is, say, 49 years old male, comes to the ER, heart rate is 190, is Afib RVR, of course, blood pressure is 70, systolic, no history at all. Patient is telling you, I have chest pain, I'm short of breath, I'm dizzy, I feel like I'm gonna die. What's the diagnosis? You already have it. What's the treatment? Cardioversion, DCCV. Don't look at the score, don't look at the fact they might have left atrial thrombus. Why? Because it's unstable. The fact that it's unstable, it's unlikely this has been going on for 2 months, right? Patient would be dead by now. This is likely that happened an hour ago or maybe 30 minutes before. Scenario number 3. Mrs. Smith, she is a 65-year-old lady. She has a history of atrial fibrillation. She was on flecainide. Then she was on propafenone. Then she was on sotalol. So she failed cardioversion. She had cardioversion ×3 in the past. Her score, or CHAD-VASc score, is 3, and she's already on anticoagulation any kind. What's your next step? Your next step is atrial fibrillation ablation, Afib ablation. Afib ablation in this case, right? Scenario number 4. Mr. Smith, my favorite patient. This time he is 75 years old male with history of cabbage, with history of ischemic cardiomyopathy with the EF of 25%, EF of 25%, history of atrial fibrillation in the past. He already got cardioverted, failed. Patient already tried amiodarone before to stay in sinus. Patient already got BiV-ICD. BiV-ICD, another name for BiV-ICD is CRT-D. BiV means BiV-ICD, one lead in RV, one outside left ventricle. ICD means defibrillator. CRT means cardiac resynchronization therapy, CRT. D means defibrillator. Same thing. What's the treatment for this case? AV node ablation. AV node ablation. You can make it more convincing or look really good in the scenario by saying he has tried amiodarone for a long time. He had 4 cardioversions in the past. We are not trying to achieve the 99% target of pacing on the BiV. This case, AV node ablation. Again, we have covered all the scenarios for atrial fibrillation. Now, few minutes for atrial flutter.